I'm Anne-Marie Doherty, the CEO of the Bob Woodruff Foundation. We're here today to learn more about a very sobering issue. Understanding and preventing suicide is a fundamental aspect of serving the military and veteran community. Despite everything we as a community collectively enact, deaths by suicide continue. Thank you for joining us to learn more about this important issue and to understand what we know, what we can count, and what we don't know.
Thanks, everyone. It is now my pleasure to introduce Dr. Rajiv Ramshan. Rajiv is the co-director of the Rand Epstein Family Veterans Policy Research Institute at the Rand Corporation. He's also a renowned research expert on military suicide, and he's conducted many studies on suicide and suicide prevention, including environmental scans of suicide prevention programs, epidemiological studies on risk factors for suicide, and evaluations of suicide prevention programs. He's also developed tools to help organizations evaluate their own programs. We're honored to have him join us today and very fortunate that he agreed to moderate this discussion. Unfortunately, one of the technical issues we were working through, we were unable to resolve. And for that reason, you won't be able to see Rajiv today, but you're going to hear him. Our apologies for that and to Rajiv, but I think, again, this discussion is going to be absolutely worth your time today. Thank you, everyone.
Thanks, Meg. I've been told I have a face for radio, so this is perfect for you all in attendance. And thanks to Anne-Marie, to you, and to the Bob Woodruff Foundation. Sorry, everyone, for my video difficulties. So grateful today to be joined by Dr. Liz Clark, who's the director of the Defense Suicide Prevention Office at the Department of Defense, Dr. Matt Miller, who is the director of suicide prevention for the Department of Veteran Affairs, as well as the Veterans Administration, and Jim Lorraine from America's Warrior Partnership, who's going to talk to us about Operation Deep Dive. The way that we set up this structure is for you all, the audience. We really want this to be your session. So please, if you have questions, you don't have to wait for any time. I'll be monitoring the chat and the Q&A section. So please ask questions as they come in. But to level set, I thought that we would start by having first Dr. Miller and then Dr. Clark provide, and then Jim Lorraine provide some very basic information just about where the data is right now so that we can have a common understanding and then have our questions and our dialogue emerge from that data. So Matt, I'll turn it over to you.
Great, thanks Rajiv, and hello to all of you, and thanks for taking time out of your day to join us and engage in this discussion and opportunity to talk about veteran service member suicide prevention and intervention. I have 3 slides that I want to walk through, maybe run through given time. The first slide is intended to lay a foundation. Second slide is intended to be more data oriented and get you up to speed on current data with regard to veteran suicide prevention. And then the third slide is more of a where do we go from here? Where are we going from here? So to lay the foundation first, I want to talk a little bit about what our annual report is and what it is not with regard to suicide prevention. We can column up here. Is not. So the first row within is and is not is veteran. And we're seeing, I think, a symbol now. We lost the share screen, but that's okay. Veteran, and that is legally defined by Congress. It includes all veterans, whether or not they were seen in VHA, VBA, or none of the above. Now, what it is not then is categories that are excluded by the law that's established by Congress. That would include former service members. Former service members, not veterans, is dependent upon certain discharge types and service length. It also does not include active duty service members. That's where Liz and team come in. And it does not include never federally activated Guard and Reserve. What it is in terms of how the data is derived, it's pulled from 50 states, DC, 5 US territories, annual death certificate records, go to the CDC, the National Death Index is created, and then VA is given access to this from CDC by cause of death, suicide, and identifying information. It is not derived from the death certificate in the box that says ever served or veteran. We found that to be less than reliable when we've matched them up. It is encompassing of suicide as defined by the World Health Organization and then converted to ICD codes. That then is used by CDC, medical examiners and coroners in terms of how they classify the death on the death certificate. That then comes to us, and then we run the analysis with our databases to match names. It does not include what's been called self-injury mortality. That adds some ICD codes under unintentional drug intoxication deaths. It adds some ICD codes under undetermined intent, such as alcohol overdose, but it does not include assault by drugs, which suicide can include. So you see here that there's this little Venn, if you will, between suicide and self-injury that's important, I think, to lay as a foundation here for this discussion. And then if you hear about self-injury mortality and calculating it, it's 100% of suicide deaths by ICD. It's 80% of unintentional drug intox deaths, and then 90% of undetermined intent. What it is then in the end is it allows for apples to apples comparisons nationally and internationally of suicide, as well as comparable trend analyses across time. What it is not, and what I think the self-injury mortality or self-injury broadly brings to the table, a little bit of apples to oranges regarding suicide, but it allows for an expanded analysis of this broader deaths of despair. For example, why are white, middle-aged, non-college educated American males dying due to overdose rates at exponentially higher rates than other Americans and international comparison groups? Important question. Next slide gives you an overview of data. I won't hit on everything here, but I'll just hit a few highlights. The last 2 years of available data, 19 and 20, we've seen meaningful decreases in veteran suicide. You can see that in the box labeled Anchors of Hope, where you'll see decreases communicated via count. You'll see decreases communicated via rate. You go to and take a look at then the line graph in the upper right-hand corner. You can see the rate of decrease for veterans at the top line versus US adult population bottom line. You can also still see that there's a gap. The gap was at its highest in 2018 at about 66% difference. It's now at 53% difference. You can see the average per day in the lower right, which everyone goes to. I've got my issues with it, but we put it on here because people want to know and they like to reference that. So let's convert this finally then to, so what are we doing about this? We're making progress, but it's not enough. We're not declaring victory. We're not saying we're there. And we're taking a look then at suicide and broader other categories such as overdose. With that in mind, the last slide. provides a little bit of overview of where we go from here. First, I think it is inaccurate to say that the VA is undercounting suicide. I'll be honest about that. I do think it's accurate to say that America has a very high rate of overdose deaths, unintentional, intentional, unknown, and it urgently needs to be addressed. That's the important point here. And so what are we doing about it? We've reported on veteran overdose death and done so via peer-reviewed journal. Happy to pass that along to you if you'd like to check it out and haven't yet. We are also, I want to highlight real quickly here 5 things. We're expanding naloxone distribution to veterans with opioid use disorder. You can see how we've had a 17, almost 18% increase quarter to quarter, recent quarters in that. We're expanding access to medication-assisted therapy. You can see that we've had a 232% increase in the number of clinicians who have prescribed buprenorphine, and that's increased 203%. We've incorporated team-based care into it, and we have a tool and a dashboard to guide that care. It's called Storm. And with that, we found a 22% reduction in all-cause mortality among veteran patients who have been identified by this prevention program. We're going to expand, and we're excited to expand staffing in substance use disorder clinics in this current year. During FY21, over 520,000 veterans with substance use disorder diagnosis receive VA care, and roughly 130,000 veterans receive that care in specialty SUD treatment. We also have 70 residential SUD treatment programs with over 1,800 beds. Finally, in the public health model, we're working real hard with our governor's challenge teams and the CDC to address medical examiner and coroner training issues regarding death classification. So with that, hopefully that gives you a solid foundation for what the data is, what it's not, where it comes from, where we are with the data in terms of the decreases that we've seen, but not good enough. And so what are we doing about it right now? Thanks, and on to Liz, I think, right?
Thanks so much, Matt, for walking through your all's data. My slides are a little bit different than Dr. Miller's. I'm really going to be focusing on what we just published this past October in our annual report on suicides in the military for calendar year 21. Our annual report represents the recent available suicide data for service members as well as their families, and we do describe our current efforts to address and prevent suicides within the department. This year's report is slightly different than previous reports. We did merge in, initially we had 2 separate reports, the annual suicide report that we call the ASR, and then the DONTS, or the DoD Suicide Event Report. This year we merged the 2 of them together. So what our report does have is it includes suicide deaths in the military community, and we release the annual rates as well as the counts. We also release the annual rates and counts for our military family members, but today I'm not going to be focusing on that. I'm just going to be focusing on service member data. In our report, we assess changes in the suicide rates by using 3 different measures. We first analyzed the trend between 2011 and 2021 to see if the rate is either increasing, decreasing, or staying the same. The second, we look at the recent year-to-year changes as preliminary insights, but not as trends. And then third, we compare to the US population after we adjust for age and sex differences, which are associated with suicide risk. And so with the slide, the rates and the counts on the top left side, you have the rates per 100,000 service members for calendar year 21 for the active component, and then separately for the reserve and the National Guard and the reserve component. Any reserve or National Guard service member who were on active duty at the time of their death are still counted in the reserve component. So as you can see, the active component rate was 24.3, which was lower than the previous year where it was at 28.7. This is about a 15% decrease. The rates for the reserve and the guard were roughly similar this year compared to last year. For the reserve, the rate is 21.2 versus the previous year it was 21.7. And for the guard, the rate is 26.4 compared to the previous year it was 27.5. And then when you look at the key comparisons, that yellow box on the top right, the suicide rates for the active component have gradually increased between 2011 and 2021, although the 2021 rate was lower than 2020. For the reserve and the guard, the suicide rates fluctuate, but there is no increasing or decreasing trend across 2011 to 2021. And then in most years, the military suicide rates are similar to the US population. I do have 2 more slides after this that I'll quickly walk through. And then on the bottom left, the suicide counts. This past year, we did have a total of 519 service members who died by suicide, most of which were in the active component, as you can see here. And then for the demographics, the service members who died by suicide were mostly young enlisted males, which is similar to previous years. Within the report, we do have other demographic factors, such as marital status, rates. They were also similar to previous years, and you can see a more detailed table within the report. And then the method on the bottom right, firearms continue to be the most common method, followed by hanging and asphyxiation. The percent of firearm deaths, the percentage of suicide deaths by firearm in the military have not changed over time. A large majority of firearm suicides are using personally owned firearms, with over 90% of those who died by firearm was from a personally owned firearm. And then the percentage of service members who died by suicide using a firearm has historically been higher compared to the US population, which really underscores the relevance of safe storage and lethal means safety initiatives for our military community. And then quickly going to this slide, as I mentioned, we have 3 ways that we assess changes with our suicide rates. And here what you can see is the first, and it's associated with the the blue numbers. First, we assess if there's a trend, which is the black line. And as mentioned, the suicide rate for the active component have been increasing since 2011 to 2021. With the second assessment, we look at the year-to-year changes with happening in that short term, but it's not the trend, but it does provide our preliminary insights. And so when we're looking at that, we also have that same measure for each of the services. And so for the services, in the short term, we saw that the Army rate was similar to last year. There was a decrease for the Navy, the Marine Corps, and the Air Force. However, the Air Force was the only statistically significant decrease. And while there was not a statistically significant decrease for the Navy and Marine Corps, it doesn't mean that it wasn't worth mentioning and it's unimportant. So we did notify or mention that here, although it wasn't statistically significant of a decrease. And then the third comparison is with the US population, and that's on the bottom left. We don't have the data for 21 yet, and so this is based on 2020. And after we standardize for age and sex, the suicide rates for the active component are similar to the US population between 2011 and 2020, except in 2012 and 2020 where they were higher. And I know I have used a lot of my time. While I can talk more about the rates for the Reserve and the National Guard, I'm going to go ahead and give my time back to Rajiv and Jim to be able to answer some of your all's questions. So I will turn it back over to you, Rajiv.
Great, and we have a lot of questions already. This is both data sources have been great. Jim, do you want to give us a brief intro to Operation Deep Dive in America's Warrior Partnership?
Yeah, Rajiv, I'd be happy to. I'm going to share my screen here really quickly. Matt and Liz, if you can just validate that I've got it, because I can see you. Thanks. Yeah, Matt, I thank you, Matt. You spelled it out really very accurately. Operation Deep Dive, the mission of Operation Deep Dive and the objective for America's Warrior Partnership was to identify the community factors that would contribute to a veteran's taking their life and to address it at the community level. What we, as America's Warrior Partnership, leading communities throughout the United States, what we noticed was that we didn't have the tools, as an example, in Pensacola, Florida, to develop a community-based suicide strategy, because we knew that the veteran who was going to take their life in Panhandle of Florida looked very different than the veteran in Buffalo, New York, as compared to the veteran in Orange County, California, as compared to the veteran in Alaska. And so the objective of Operation Deep Dive was to gather community-based information down to the zip code, down to the counties, and identify the veteran. The goal was to identify the veteran who was at greatest risk or had the highest probability of taking their life, so that we could say the veteran who we should do outreach and engagement to, who has the highest priority, looks like this person as we go forward. We were fortunate to have 8 great states that shared their data with us. We are constrained by 8 states in the interim report. One of the expanding pieces that we have as we've gone forward with Duke University School of Medicine is that those 8 states are growing. So we have the 8 states, plus we're adding, right now we have 4 other states that have lined up to say, hey, we'd like to share the data. The process that we went through is that the states shared all of their death data with us. States were required, the minimum information we needed was name, social security number, date of birth, and gender, so that we could make a match with the Department of Defense. And Liz and her team and the Defense Manpower Data Center have been great, where we send the death information, we send actually the identifiable information to DoD, who then sends us back 135 columns of data related to the military service members. So it identified people who never served in the military, and it identified people who actually served in the military. One of the reasons we constrained our report and our work to between 18 and 64 was that DMDC wasn't confident of those service members who had served prior to 1971. So we drew the line at 64 because everyone who was 64 or younger had to have served after that period of time. So what DOD sent back was very detailed record. So we can look at a service member. So Jim Lorraine, if my name was up there, it would show that I joined the reserves in 1983. I left the reserves in 83 and then went active duty until from 85 to 2005. And then I was honorably discharged and went on. It would also show all of my duty assignments. It would show my MOSs. It would show my deployments. It would show if I had a disability. It was the data was very robust. So we had death data and we had service data. So we could look, and the death data included not only where the veteran lived or the former service member or the person lived, but also the zip code of where they died. So we could then look down to the zip code level if the population was large enough and identify what did they have in common? What was unique about Pensacola, Florida, as compared to Miami, Florida, as compared to Jacksonville, using Florida as an example. And so when we brought all this together as part of the interim summary, we noticed that at the community level, obviously there were differences. We could notice differences between rural and urban, but we were able to see the differences between the states. So Florida was very different than Massachusetts, was very different than Montana, and it validated what we went in thinking, which was veteran suicide prevention or premature death prevention is a one-size-fits-one approach. While there needs to be a national strategy and a state strategy, it needed to be more applied down to the local level, which we could do. One of the things, and to go to Matt, I agree 100%. The suicide per day thing, I wish we had never brought that, had never come out. It's more accurate to look at obviously a rate per 100,000 because you can do far more comparisons. So in the slide that I have here is what we put out, what we found. What we found was, if you look at the dash marks, it came from the CDC. This is the rate per 100,000 of overdose and suicide amongst the American people. When you look above it, the gray line there is the published rate per 100,000 of the VA's rate between 2014 and 2018. And again, just to talk a second about the timing, we only use 2014 to 2018 data. We had 19, 20, and now we have 22 data, 21 and 22 data that we'll process. But what was complete were those 5 years. The dotted line is the VA's reported suicide rate, sorry, and then the gray line there is a thing called self-injury mortality. And then when you go up above it, the orange line that you can see in your graph is what we found was the suicide rate amongst former service members. I want to just talk about that for a second. Because we had their entire service history, we tried to get as close to what we could to the VA's definition of, and the government's definition. I shouldn't just say the VA, but the government's definition of a veteran. And that is active duty for a period of time, 180 days of full-time orders. And remember, when we received the data back from DoD, it was really robust. So we could see somebody who did a couple of years of active duty, 3 years of active duty, and then went in their guard, and they may have jumped over to the reserves. We could see their entire service history. We could also see their deployments, those who were combat deployments, OEF, OIF, etc. The Philippines, you know. And so what we did was we filtered everyone. When we counted this number, we filtered everyone who didn't meet that criteria. They're filtered out of this number. So we tried to get as close to we could, but we didn't use the term veteran because that's up to Matt to decide who's a veteran or not. We wanted to just use the term former service member.
Jim, I'm gonna cut you off, okay? Because we have 30 questions, and so I just want to make sure that we address those.
So real quick, Brigitte, just real quick, we're moving to we're excited to move forward. We're looking forward to continue to work with DoD. We look forward to working with Matt and his team. I think our mantra is together we can do better, and we're happy to work together. But there you go. Thanks, Rajiv. Sorry, I'll move it. I'll stop sharing. There you go. Thanks.
Great. So I'm just going to go directly to the questions in the chat, which are quite interesting. I think that this one kind of goes to Matt, but I'm going to actually pivot it a little bit to Liz because I think that something that often gets lost in the discussion about suicide risk is this transition period. And this question really comes about, are we going to talk about humanitarian assistance for behavioral health conditions in the VA? And what is really, I think, at the core of this question is people who may not be eligible for care because of an other than honorable discharge, which kind of occurs in the military setting. So I wonder, Matt, if you could start with if the VA is doing anything with respect to those with other than honorable discharges who may not be eligible for the full suite of services. And then Liz, maybe if you could talk to, that process when somebody, something happens and they start going down that pathway towards, some type of discharge status, other than honorable discharge status, what efforts might be in place within the DoD setting. So Matt, I'll go to you first.
Sure. Recent legislation has really helped to pave new roads for us to be able to address VA care, if not actual enrollment for veterans with a OTH designation at discharge. I was looking at some statistics the other day and noting that with the changes to legislation, I think FY22 there were I want to say about 11,000 veterans with OTH designation who submitted to VBA for reanalysis under new rules for benefits, or at least registering for services such as mental health. And of that amount, 75% had their situations re-adjudicated favorably for receipt of care. Now, that's what we can do. What we can't do is change the designation of discharge that's assigned and placed in the file. That's with a different service. So, Yes, we are working in a concerted manner regarding other than honorable and services available, particularly mental health. And we have seen some pathways and ways forward, along with some solid numbers towards change and positive change at that.
Yeah, and if I could just add in, Matt, thanks so much for mentioning all that. And right now, that is such a big focus that I think Dr. Miller and I have, is looking at the transition period a year prior to separation or retirement, and then a year afterwards, and really focusing efforts on that to include the other than honorable discharge service members. I will say on the department side, each of the services, as well as the different transition assistance programs, really does wrap their arms around the other than honorable discharge population. Each one of them also has the opportunity to work with in transition, that is helping them with that warm handover to services that they have when they do separate from the military. But this is definitely an area and population that Dr. Miller and I are keenly looking at, and then excited to be able to continue that conversation and support services around that population moving forward.
Thanks, Liz. Jim, I want to pose this one to you first. There are a few questions and then Liz and Matt, if you have anything to add, please do so. There's a lot of questions about this overdose death and what gets counted as a suicide and what doesn't. So we know that suicides, from a medical examiner perspective, they need to show that the act was self-intentional, that it was self-inflicted, and that there was also an intent to die as a result of that. So overdoses, especially when there's not, evidence, a suicide note, for example, or things like that, it becomes a really gray area. So what do you have? I mean, you kind of presented data on this self-inflicted injury that Matt talked about. What do you think is going on there, and with respect to this overdose, and how that gets classified or how that doesn't with respect to suicide?
Yeah, thanks, Rajiv. So just to be clear, when we categorize suicide, it's what Matt defined under suicide. It's exactly that. It included overdoses that were categorized by the medical examiner or coroner as a suicide. What we looked at on self-injury mortality was, as Matt described, the overdoses, predominantly overdoses, that were either categorized as accidental or undetermined. There was a lot of research that's been done about self-injury mortality, and really the reason why we identified them was not to combine the two. That is not, they're not to be combined, but it's to say this is what the suicide rate was. And then, oh, by the way, we need to look at the self-injury mortality, because what we found was the self-injury mortality was at such a high rate and a high level that we felt that it needed additional consideration, especially those that under self-injury mortality are considered possible or probable suicides, the 80% and the 90% that are reported as accidents and undetermined. Our point there is suicides are terrible. Let's not lose our sight on self-injury mortality, because it's a growing threat that is coming our way, and that we need to be cognizant of it. And that's really the driver. That's the reason why we split it out. And I think it's important to notice that. And I think that when we talk to the CDC, it's how do you standardize reporting? And as you said, Rajiv, unless there's a note or intention, it's tough to determine. But honestly, when you read some of the medical examiners reporting and you see an accidental suicide, an accidental suffocation with plastic and duct tape, you really sort of have to go, all right, was that an accident? Or there's a lot of bias at the local level on stigma, on financial implications, and on other reasons. And that's what these coroners and medical examiners are faced with much of the time, is the stigma of quote unquote suicide.
Right. I don't know, Liz or Matt, if you want to add anything. I would say, Jim, that it's increasing and it's not, coming our way. I think we're in the midst of it right now, this kind of overdose epidemic. But I don't know, Liz or Matt, anything?
I could just add in quickly, Jim and I have had lots of conversations about looking at the data differently. And I think, me coming into this role new, a month into it now, is this is something that is very important to me to look at, not just our suicide related data, but looking and opening up our aperture differently and looking at the data through different lenses. And so very much appreciate Jim's work and AWP's work on being able to really look at this. And Matt, I know you and I have talked about this as well, of how do we look at data writ large to understand the population and some of the things that are happening.
Yeah, I think it's important, as we're hopefully assisting with in this discussion, and in understanding suicide and how it's defined currently, and self-injury mortality and how it's defined currently, and then making sure that we're talking about the right ones accurately, and that can be very challenging to do. And that's why I go back again to the point, we're not undercounting suicide. That's the last thing we want to do. We want to be fully transparent. But if you were talking in the context of self-injury mortality, that's then when you're adding these other codes and these overlapping issues. And that's where you get into the really important discussion about prevention and intervention. And, I think these discussions can be instrumental towards helping move us along in those ways. Rajiv, this goes back to what? I mean, was it 2015 or so, the original paper on deaths of despair led to the book? And some follow-up work on that. Jim, I know you worked with Eric Kane and Rocket a little bit. They have work dating back to 16 and 21 on self-injury mortality. I think it's going to be really interesting to see how well the equation, if you will, continues to test out with the data, where you take 100%, 80%, and 90% of those categories. Does that give us a good sense of this combined category? I think there's usefulness in continuing to pursue that.
Rajiv, I would just add, I think if it's preventable, we should act on it. And I'm not saying it's under the VA Suicide Prevention Office, but I'm saying the VA writ large, DoD writ large, the community, the nation writ large, should be, if it's preventable, we should be taking action on it, whether it's categorized as a suicide or I agree we need to figure that out. But that's one of the reasons why we wanted to highlight this was, hey, we've got work to do. Matt, you said we're not done, and I agree 100%. We're not done, and we all need to be rowing in the same direction together.
If I could also add too, and I think that's why we were all so excited to be on this panel together and to have these conversations. While we might work individually, but working together as a group and having these type of discussions, because while I have 519 suicides that I talked about for last calendar year, that's only 519 on these military installations, as well as with the Guard and the Reserves. But that doesn't mean that then what's happening in the community, what's happening across the state, what's happening across the nation, and for us to really look at this data from each one of those lenses, as well as enhance that what's happening with opioids, with other type of self-injury and different deaths. So we're just so grateful to be able to have this opportunity to start sharing our data and looking at it in different lenses.
Great. Thanks, Liz. I want to get to you spoke, Liz, about the Air Force, significant reduction, but a reduction in suicides in the DoD. And Matt, you showed the data to show reduction of suicides among veterans. And I do think that that's, we should be cautiously optimistic. Colleagues and I looked, there was research to show that COVID, with respect to suicide, COVID disproportionately affect racial and ethnic minorities. This is in the general population. And we found the same thing, that as the general suicide rate in the United States has decreased in the past 2 years, it hasn't decreased for racial and ethnic minority groups necessarily, especially Asian Americans and Black Americans. I'm curious, are there groups for which you're not seeing a decrease that you're concerned about? Who is kind of right now? I mean, we could talk about whether the decrease you're seeing is attributed to your groups, but where do you see risk higher, and where do you think efforts are needed, targeted prevention efforts, perhaps, among your populations that you serve?
Yeah, Rajiv, 18 to 34 year olds, veterans, keeps me up at night, honestly, and without hyperbole. It's the one age group that has not had a decrease in suicide rate. And it's why I'm sitting down this year with our Suicide Prevention Center of Excellence, and I'm asking to partner with them, and I'm asking to develop a specific wing of the center focused on 18 to 34 age group and veterans, and research, program evaluation, community-based work, clinical work to help turn this around. I think a key with that age group for us right now, as best as we know, starting point, firearm lethal means safety. That group, as well as veterans as a whole, 70% of suicides are secondary to firearm, and many of them are seemingly impulsive acts. So engaging in firearm-related lethal means safety at the clinical level, but also at the community level through our Keep It Secure paid media campaign, I think is where we have been focused, but we need to do more. And that's why we're talking about advancing it through this focused aspect of the center.
Liz,
And if I could, sure. While our highest risk demographic is young enlisted males, under the age of 30. And me coming new into the seat right now, while I can look at lots of efforts to really hit that wider demographic group, I think Dr. Miller hit it perfectly when we're really looking at efforts towards lethal means safety initiatives. That is going to reduce suicides when we put in those safe store messaging and those lethal means safety initiatives. But coming new into this role, I'm really looking at the smaller populations, and while they're not the highest risk and they're not the biggest numbers, it doesn't mean that they're unimportant. And so I'm working very hard to create a strategy right now of focusing in on the Black African Americans, the AIAN population, as well as the Asian and Pacific Islanders, because those numbers also matter. And just because they're not as big of a population with our overall data doesn't mean that they're unimportant. And so I'm working really hard right now internal within the department, as well as the other federal agencies, to make sure that we can look at interventions and programs and initiatives to be able to support those specific populations as well.
Thank you. Sorry, go ahead.
No, Rajiv, I was just going to add one thing, just based on the data that we found. I think, we fully support, and I 100% support lethal means safety, especially firearm. But I think when you look at the states, like when you look at Massachusetts, Massachusetts' #1 cause of death that we found was actually strangulation, followed by overdose, and then lower by firearms. But when you look at their firearm laws within the state, that sort of makes sense. So, and then when you look at Minnesota and you look at the female population, the highest rate is strangulation, whereas firearms are lower. That's where I'm getting to the point of a one size fits one. That I agree with my colleagues here that we've got to look broadly, but we also need to look specifically, in that a safe storage may not be as effective in Massachusetts as it would be in Montana, whereas focusing on overdose, et cetera, maybe, or other means may be more important.
Great, thank you. And I know that we only have 5 minutes left, and I'm sorry for cutting this short because there's so many questions. But what was just stated, I think it ties in, Liz, both your statement and Jim yours, to the last question that I want to ask, drawing from some of the questions in the audience. What we're not capturing. So some things that we're not capturing in the data are things that I'm really interested in and have published on, like suicide risk among lesbian, gay, bisexual, transgender, queer, questioning populations, including among veterans and service members. So there are these populations for which we don't have data. The other thing is, given how rare suicide is, it's often we don't have it at the community level. And that's where so much prevention happens. That's where America's Warrior Partnership is based. That's where Bob Woodruff Foundation's Got Your Six is anchored. It's in these communities. So how can we use data to inform community level efforts? And like Jim said, in Massachusetts, the methods of suicide are different. So I kind of throw that out to all of you within 4 minutes, this big question. But I do think we really have to be working at the community level and thinking about how we can use data-informed strategies at these community and the challenges there, because we don't have data or we have such sparse data. So I wonder if any of you have thoughts on that.
Rajiv, I'll jump in real quick, and I promise I will be really quick. One of the things, the other components, I talk a lot about the quantitative piece, which is what we reported, but Operation Deep Dive has a qualitative piece where we're doing interviews with surviving family members of those who have taken their life. And that qualitative piece gets to your question about the LGBTQ community and a little bit more fidelity, where state records or DoD records may not be listing someone's gender. The other thing that I'll close with and I'll turn it over is we're so focused at America's Warrior Partnership on the who and the why, and we're focused on the how, but it's really using the how someone takes their life to get to who are they and why are they getting to this point. And I think all together we can do better with that, but I'll turn it over to my colleagues.
Sure, and I'll be very quick as well. We are looking at within the doctrine of including gender identity and sexual orientation as well in the upcoming years. But I also just want to give a huge shout out to Terry Tanelian at the White House Domestic Policy Council, because she has really brought together all the federal agencies right now. We are having the discussions about smaller demographics and populations of interest, and looking at our data sources and being able to start sharing the data writ large to the group. And so I think we are moving in that direction, and really excited to be part of that conversation. But I will just pause and Dr. Miller, anything else that you wanted to add?
No, I think you both covered it very nicely. Thank you. I'll leave it at that and make sure Rajiv has a little time here.
Well, I'm just going to use the 2 minutes to ask a separate question for Liz and Matt. Thinking about the community level, are we looking at suicide risk at the installation level or at the VA hospital or facility level?
So very quickly, we are within the department. We call them OCs, the on-site installation evaluations, where we are looking at risk indicators down at the installation and the unit level, and then as well as making visits to see what's going on, and that's to include many prevention type of things such as sexual assault, sexual harassment, suicides, toxic leadership, and then the culture. So we are really looking at that, not just at the installation level, but down to the unit level.
Yeah, and we're looking at it at the facility and at the regional levels. Within that, what we're finding, Rajiv, is that at the facility and the regional levels, the veteran rates very closely parallel the U.S. adult population dynamics and rates specific to that area. And then we compare it to the veteran, the amount that the veteran rate is higher, 1 to 1.5%. And then we also take a look at it in terms of, is it different from that 1.5 times higher? If so, that means there's even more risk in these areas. What we find from that is areas that tend to be higher concentrated with veterans, rural, access to lethal means and firearms. That's where our highest risk is, that from a population perspective.
Great. Well, I just want to thank, first and foremost, the Bob Woodruff Foundation for bringing us together today to have this important dialogue. I want to apologize for my video difficulties, but finally, most importantly, thank Liz, Matt, and Jim for such an insightful discussion. Thank you all so much really admirable, all the work that you're doing to prevent these preventable deaths. And I'll leave it there. We'll all have work to do, as it has been stated, including those. And thanks to all of those who joined in, who I know are very passionate about this issue and doing a lot of work on their own to help mitigate and minimize the stressors and prevent more of these untimely deaths. So thank you all so much. I really appreciate it.
Thanks, Rajiv. Thanks.
Thanks,
Thanks,
everyone.
Rajiv.
Thanks.